We are going to continue as we look at the part 2 of insertion and removal of intrauterine contraceptive device. In this particular teaching, we are going to see intrauterine contraceptive timing, insertion, removal, the adverse effects, and the management. But before, let's look at the learning outcomes for this particular unit. We are going to describe the appropriate timing of intrauterine contraceptive insertion. We are going to state the steps for intrauterine contraceptive device insertion and removal. We are going to discuss the adverse effects of using an intrauterine contraceptive device, and also to describe the management options for adverse effects while using intrauterine contraceptive device. For the timing, intrauterine contraceptive device can be used within the first 7 days of the menstrual cycle, and anytime it is reasonably certain that she is not pregnant. So before using the intrauterine contraceptive device, it will be good to make sure that the woman is not pregnant. So we have to rule out pregnancy test through pregnancy through pregnancy test. And then that is if it's after 7 days of her menstrual cycle. But if the woman is still within the menstrual cycle, then we don't need to do the test. For the postpartum, in the postpartum period, we can use the intrauterine contraceptive device within 10 minutes to 48 hours or after 4 weeks. And also for abortion, post-abortion, it can be used immediately, because immediately following the abortion period, the uterus is still up, so above the umbilicus. So when it is inserted, then it will involute together with the uterus. Also, in the timing, we can switch from another method. That means if the client was using another method before, the client can switch from that method to using the intrauterine contraceptive device. It is safe, there's no problem. And also, it can also be used as it can be used for emergency as emergency contraception within 5 days, within 5 days of exposure to unprotected sexual intercourse. Of course, like I said, that everything comes with its shortcomings. Even the intrauterine contraceptive device has some adverse events that may occur, and some of them may include the missing strings, perforation. We may have perforation, for example, if the provider is not competent enough, and if he's not competent enough during the period of insertion, he may exceed the endometrium of the uterus and perforate into the abdomen. Sometimes also, due to incompetency, there can also be expulsion of the intrauterine contraceptive device, especially when it is not properly inserted. And we may have some incidents of heavy and prolonged bleeding may also occur. And of course, infection can also occur, but the infection is not due to the intrauterine contraceptive device. The infection may occur due to poor hygiene. If we have if the person who is inserting the intrauterine contraceptive device did not respect infection control technique, then the person may introduce infection to the uterus through ascending infection to the uterine endometrium. And also the pain, sometimes there might be pain due to misposition of the intrauterine contraceptive device. That means when it is not properly inserted and it is mal-positioned, then that may expose the client to pain. Now let's see how we can manage the different types of events or adverse effects that may arise due to the use of the intrauterine contraceptive device. The first one we are going to be looking at is, for example, if we have the missing string. For example, I have set some scenarios or some situations that may be due to the missing rings. For example, intrauterine contraceptive device in situ but the strings are coiled or retracted or broken. What can we do? Uterine enlargement. Sometimes we may have some medical conditions like myomas like fibromyomas, like fibroids, or even sometimes when we have pregnancy. Rotation of the intrauterine contraceptive device. Sometimes we may have the rotation of the IUCD due to poor insertion technique, and sometimes it may also have been expelled from the uterus. Again, like I explained previously, that sometimes intrauterine contraceptive device has perforated the uterus and is in the myometrium or in the abdomen. How do we manage the missing strings in case of intrauterine contraceptive device? The first thing we need to do is to exclude pregnancy. If the client is not pregnant, then we confirm it where the actual position of the intrauterine contraceptive device. We have to confirm if it is in the intrauterine. If the client needs it, we have to leave it in situ. If not in situ, then we have to remove the intrauterine contraceptive device and replace with a new one. The management of the missing string will continue with the management of intrauterine contraceptive device. When we exclude pregnancy, probe strings with cotton brush or forceps. The IUCD not located, then we may perform an ultrasound, because as you all know, the ultrasound will help us to identify the actual position of the intrauterine contraceptive device. It will help us to know or to identify if it is in the cavity. If it is in the cavity of the uterus, leave it unless the woman wants to discontinue using that method. If removal is chosen, for example, the client may choose that the intrauterine contraceptive device should be removed, ultrasound guided removal or dilatation and curettage of the cervix, and the intrauterine contraceptive device can be removed. If not visible, for example, on ultrasound, because sometimes when they perform the ultrasound, when it is deeply embedded into the endometrium of the uterus, then it may be difficult sometimes to see it with the ultrasound. Then we may do abdominal or pelvic X-ray. Even when it is not visible, then we confirm expulsion. But if the X-ray shows that the intrauterine contraceptive device is located outside the uterine cavity, then we have to think that a perforation has already occurred. Again, that is for the missing string. Now, if, for example, the adverse event is due to heavy or prolonged bleeding, what can we do? The first thing we have to do, we have to reassure the woman using intrauterine contraceptive experience heavy. Most times, women that have intrauterine contraceptive device, they may experience heavy or prolonged bleeding. So we need to reassure the woman or the client that it is normal for them to experience heavy or prolonged bleeding, especially within the first 3 months of insertion of the intrauterine contraceptive. So what we need to do is to use our good counseling skill properly. Then for modest short-term relief, she can try non-steroidal inflammatory non-steroidal inflammatory drugs, but not aspirin, except for aspirin. Then we can provide iron tablets, because if the woman is experiencing heavy prolonged bleeding, that means she's losing a lot of iron, and then of course that may lead to anemia. Remember what I talked about when we were talking about the misperceptions on the first part of this presentation. So in this case, if the woman is experiencing heavy or prolonged bleeding, then we can provide iron tablets. And of course, we encourage the woman to eat a lot of foods that contains iron. If the heavy or prolonged bleeding continues or starts after several months, then we need to consider underlying conditions unrelated to the method used. We need to consider other conditions that may make the woman to experience heavy or prolonged bleeding. Like we said, we can consider maybe, for example, myomas. The woman may be having myomas, and these myomas, like fibroid, may also show similar clinical presentation like when the woman was using that intrauterine contraceptive device. So we need to rule out those medical conditions also. Let's see, in the management of perforation, for example, remember I said that another complication may be perforation of the uterus. So if there is perforation of the uterus, normally it occurs during intrauterine contraceptive insertion in 1 in 1,000 or less. So usually it may happen due to the poor skill of the healthcare provider. And the risk factors may include, like I said, clinicians' inexperience, when the person who is doing the insertion is inexperienced, or when we have some conditions like retroverted uterus. For example, if there is a retroverted uterus and the presence of a myometrial defect in the uterus, usually recognized immediately. Sometimes it may be recognized immediately with the use of ultrasound. And the signs and symptoms may include shortening or missing string. Sometimes the patient may also complain of the abdominal pain and or bleeding. We can do, the diagnosis can be done through the use of an ultrasound. If not visible, then we may perform an X-ray like we have said earlier. Then in the management, removal by laparoscopy or laparotomy may be done. If the intrauterine contraceptive device is deeply embedded into the myometrium of the uterus, then we may perform a hysteroscopic removal of the IUCD. Again, if the complication, maybe for example the patient experiences infection, the greatest risks in the first 20 days after insertion, the woman have the chance to have infection within the first 20 days after insertion. But remember, I told you earlier that the infection is not due to the intrauterine contraceptive device itself, but due to contamination of the intrauterine contraceptive device. It may be due to using unsterile procedures or techniques of insertion. So, or maybe the woman has already a sexually transmitted infection before the insertion, or maybe she has pelvic inflammatory diseases before the insertion. So that will increase the incidence of her developing infection after the insertion. If, for example, the woman experiences infection, we have to initiate treatment immediately with the intrauterine contraceptive in place. And if no response to the use of the treatment, if no response of treatment within 72 hours, or other complications like tubo-ovarian abscess is suspected, then we have to remove the intrauterine contraceptive device and then treat. Now, if the complication is pain, for example, but I told you that the pain really is not due to the intrauterine contraceptive device. The pain may be due to malpositioning, due to poor technique of insertion. So the client may experience cramping or abdominal tenderness. Okay, so we need to evaluate for pelvic inflammatory diseases. We need to evaluate for ectopic pregnancy. Is very important. If the patient comes and complains of pain, especially if the patient is complaining of a right upper quadrant of right lower quadrant pain, or then we need to think of some differential diagnosis like ectopic pregnancy, threatening abortion, incomplete abortion, or expulsion or perforation of the uterus. Sometimes also the pain may be related to dysmenorrhea, and if we suspect that the pain is due to dysmenorrhea, then we have to treat by using non-steroidal anti-inflammatory drugs like ibuprofen, for example, as prescribed. Or the patient should be encouraged to see her doctor in order to give appropriate anti-inflammatory drug. The partner may be feeling the string also, which can also lead to the pain. If the strings are cut too short, then she may be feeling the edge, because when it is too short, the edge will be touching on the head of the cervix, of the anterior fornix of the vagina. So the woman may be experiencing some kind of pain or crampings. So when after inserting the IUCD, it is important to be sure that when you are cutting, you make an estimate of between 3 to 4 centimeters from the horse. Again, please, it's very critical for us to think about counseling. Counseling is very critical in the management of all the adverse events that may occur as a result of using an intrauterine contraceptive device. Let's look at the 8 major intrauterine contraceptive insertion steps. We have 8 major steps. In the first step, we have to conduct a pelvic examination to assess legibility. The provider first does the bimanual examination and then inserts a speculum into the vagina to inspect the cervix. In the second step, clean the cervix and the vagina with appropriate antiseptic solution. In the third step, insert the tenaculum through the speculum and close the tenaculum just enough to gently hold the cervix and the uterus steady. Slowly and gently pass the uterine sound through the cervix to ensure the depth and position of the uterus. Then in step 5, load the intrauterine contraceptive device into the inserter while both are still in the unopened sterile package. Cut the strings in the IUD, leaving about 3 to 4 centimeters, like I said earlier, hanging out of the cervix. After the insertion, allow the woman some time or some minutes of rest. She remains on the examination table until she feels ready and comfortable to get dressed. She remains on the examination table until she feels ready to stand up, and then you may make her comfortable and of course give her other advice. For the post-insertion follow-up, it should be within the first 3 to 6 weeks. In the first step, ask how the client is doing with the method and whether she is satisfied with the method. Ask if she has any questions or anything to discuss. You have to use an open-ended question, so that you allow the client to express how she feels about that method. If there are issues that she may want to discuss with you, if she's satisfied with the method, allow her the chance and the opportunity to express how she really feels about that method. Ask especially if she's concerned about bleeding changes. Give her any information or help that she may need. Then in step 3, in the follow-up, ask if she has increasing or severe abdominal pain or pain during sex or urination. For example, if the woman says that she has pain during sex or during urination, you can think of sexually transmitted infection. And like I said earlier, the sexually transmitted infection is not the intrauterine contraceptive device, but there are conditions that may have existed before, or conditions that may have been transferred through ascending infection. Also, you may also ask if she has any unusual vaginal discharge. If she has unusual vaginal discharge, you look at the vaginal discharge. What is the color? What is the consistency? What is the amount? Is she feeling fever or chills? If the woman is experiencing these signs, of course, it is easy for us to conclude that the patient may be having infection. So you have to take samples to the laboratory and then do proper follow-up. If it is positive, then you treat. Again, if we have signs or symptoms of pregnancy, for example, if the woman is complaining of maybe heaviness on the breast, early morning sickness, etc., then you can send her for pregnancy tests to rule out pregnancy. Not being able to feel the strings. If she has checked them and she says she's not feeling the strings, so you may check yourself and be sure if the strings are still intact. Felt the hard plastic of an IUD that has partially come out. Sometimes the woman may also say that she's feeling the strings at the lower uterine segment. If she's feeling the strings at the lower uterine segment, you have to confirm through vaginal examination. So when you perform vaginal examination and it is confirmed that the strings or the hard plastics of the IUD is being felt either at the lower uterine segment or at the lower house, then it has to be removed, and then if with the patient's consent, then you have to replace by inserting another intrauterine contraceptive device. We have three major steps of intrauterine contraceptive device removal. Before removing the intrauterine contraceptive device, explain what will happen during the removal to the client. Help her to understand even what she will feel. If there are anything she's supposed to feel, you have to make her to understand properly. In the first step, insert a speculum to see the cervix and the intrauterine contraceptive device, the strings, and then carefully clean the cervix and vagina with an antiseptic solution such as an iodine or what is used within the policy of the hospital. Ask the woman to take a slow, deep breath and then to relax. The woman should say if she feels pain during the procedure. Using a narrow forceps, pull the IUCD strings slowly and gently until the IUD comes completely out of the cervix. As we go to the next slide, I would like you to watch this video on the insertion of intrauterine contraceptive device.
IUD technology has come a long way since the first plastic devices, such as the Lippes loop, appeared on the scene in the 1960s. Towards the end of that decade, it was discovered that adding copper to the plastic made the IUD more effective in preventing pregnancy and caused bleeding problems to occur less frequently. The first copper-bearing IUDs were produced in the early 1970s, but they required replacement every 2 to 3 years. Further research at the end of the 1970s produced IUDs with larger quantities of copper. Among the better-known examples are the copper T380A, the copper T220C, and the multi-load 375. These devices not only reduced the incidence of side effects compared with previous IUDs, but also had significantly longer lifespans and lower failure rates. This video demonstrates the insertion technique for the copper T380A IUD, which has been shown in a Cochrane review to be more effective than other IUDs. Have ready in an easy-to-reach position a vaginal speculum, the IUD to be inserted, and the applicator on a sterile surface. Ensure that the woman is in a comfortable position. You should have already explained the procedure to the woman and responded to her questions and concerns. This helps the woman to relax, making insertion easier and less painful. Perform a pelvic examination to rule out genital infections or abnormalities, as well as to ascertain the position of the uterus. You will need to follow appropriate infection prevention procedures, including the use of sterile instruments and cleaning of the cervix with a water-based antiseptic such as chlorhexidine. Insert the speculum into the vagina to have a clear view of the cervix. Cleanse the surface of the cervix with an antiseptic swab. Grasp the upper lip of the cervix with a tenaculum forceps to allow, if needed, application of gentle traction to straighten the angle between the cervical canal and uterine cavity. Assess the angle of the cervical passage and depth of the uterine cavity by gently inserting a uterine sound through the cervix until you feel the sound has touched the fundus. Note the depth of the uterus by counting the number of notches on the sound visible from the cervix. The copper T380A IUD comes with its inserter in sterile packaging. Using the no-touch technique, load the IUD into the inserter while both the IUD and the inserter are still in the package. Here is how it is done. Pull the inserter tube to let the IUD lie freely in the loading capsule. Then, by squeezing on the sides of the loading capsule, bring the horizontal arms of the IUD close to its vertical body. Now push the inserter tube forward to capture the body and the two arms of the IUD in the inserter tube. Once the IUD is captured, it should be inserted into the uterus within a few minutes. Push the blue flange on the inserter tube to a point that corresponds to the depth of the uterus you had measured with the sound. Remove the loading capsule, but maintain traction on the two strings at the lower end of the IUD to keep the device in position. Introduce the plunger into the inserter tube until it reaches the lower end of the IUD. Holding the tenaculum forceps with one hand to ease passage for the inserter tube, introduce the loaded inserter tube into the cervical canal until the blue flange reaches the mouth of the cervix. Holding the plunger steady, pull back the inserter tube a couple of centimeters to release the arms of the IUD inside the uterus. Then, first remove the plunger, and then the inserter tube. The final step in this procedure is to cut the synthetic threads to about 2 centimeters from the cervix.
In the summary, based on what we have discussed from the introduction and from what you have seen in the video, we have seen that intrauterine contraceptive devices are safe, effective, they are convenient, they are reversible, they are long-acting, they are cost-effective and easy to use. Providers can ensure safety by careful screening, informative counseling, good infection prevention technique during the insertion process, proper follow-up of the client, good timing for insertion, and management of adverse events. Thank you for your kind attention.